Hi there, this is Katie Lynn. I'm an emergency physician, stroke physician, and critical care air transport physician based out of Calgary, Alberta. Let's take a dive into the world of neuroprotective airway management. If you have a patient with a neurocritical condition, whether that's severe traumatic brain injury, intracranial hemorrhage, subarachnoid hemorrhage, or stroke, you need to approach your airway management with extra caution because the peri-intubation period can be fraught with peril. Let's review some tips around neuroprotective airway management that you can bring to your next case. Tip number 1, consider airway management prior to imaging or transport. Remember that neurocritical conditions can deteriorate quickly once things progress beyond the range of the brain's ability to autoregulate. So a lot can happen on the journey to CT and back or during transport to another center. Ask yourself, is your patient with suspected intracranial injury actively vomiting, too agitated to lie still, rapidly dropping their GCS, or having apneic spells? If so, it's time to think about airway capture now. The threshold to intubate in the setting of a suspected intracranial disaster is lower to ensure that time-critical neuroimaging, transport, and/or other interventions can be completed quickly and safely. Tip number 2, include a 10-second neuro exam pre-intubation if at all possible. Include a very quick neuro exam for critical findings before you intubate. It should take no longer than 10 seconds. Once the patient is intubated, the neuro exam becomes limited, but our stroke, ICU, and neurosurgery colleagues often rely on certain critical findings to make the ultimate go or no-go decision on definitive management once an imaging diagnosis has been confirmed. There are 2 questions that our consultants care about most. First, is the patient herniating or severely disabled by their intracranial condition? This is to help determine the urgency of intervention. And second, is the brain still salvageable with intervention? This is to determine if intervention makes a difference in the outcome. What does this 10-second neuroexam look like? Easy. It's 3 components that you're already familiar with: GCS, eyes, and lateralizing motor response. GCS. What is the patient's GCS, and is it actively dropping from what it was before? Eyes. Are the pupils equal and reactive? Are the eyes disconjugate or deviated to one side? And if the patient is unconscious, are the corneal reflexes intact? Lateralizing motor response. What kind of motor response are we seeing? And have we seen with our own eyes movements that are purposeful and equal bilaterally? Or is there asymmetry or posturing present? GCS, eyes, and lateralizing motor response. Tip number 3, keep it simple and avoid hypotension and hypoxia. In a crashing brain, when things are going downhill fast, choose the tools and approach that you are most experienced with. There is no single right way, but rather the best approach is the one that you know well and wield often. Choose the tools that you are most comfortable with, and don't complicate things by adding unfamiliar elements under stress. The key is to avoid hypotension and hypoxia throughout the peri-intubation period. For me, this looks like an RSI, provided there are no predictors of an anatomically difficult airway. If we look at the P's of RSI, I pre-oxygenate with a non-rebreather over high-flow nasal cannula at flush. I pre-treat with an antiemetic if the patient is vomiting, with fentanyl if the patient is hypertensive, or with a vasopressor like phenylephrine or norepinephrine if the patient is hypotensive, all while setting up the rest of my equipment. I prepare my equipment. This includes verbalizing to the team what my plan A, plan B, and rescue plans are in the event of failed airway capture. I ensure that the team is aware of my predefined oxygen saturation threshold that someone can help keep an eye out on and call out that will let me know when I need to back out and reoxygenate if needed. I typically use a threshold of 90% SATs. I make sure that my drugs and equipment are accessible at the bedside and that I have rescue equipment, including a BVM, LMA, bougie, and cric kit near at hand if needed. I position the patient with the head of the bed at 15 to 30 degrees to mitigate ICP effects. Even in patients who have spinal precautions, I use reverse Trendelenburg to the best of my ability to ensure that I can get as close to this positioning as possible. I induce the patient with ketamine typically, at a dose of 1.5 milligrams per kilogram if the patient is hemodynamically stable, or at a reduced dose of 0.5 milligrams per kilogram if the patient is hypotensive. Ballpark doses are about 100 to 150 milligrams for the average-sized hemodynamically stable adult, or reduced doses of 25 to 50 milligrams for the average-sized hypotensive adult. I paralyze with either succinylcholine or rocuronium. The advantage of succinylcholine is that it wears off quicker, so you can resume your neurologic monitoring much sooner. Although studies suggest that there may be a brief spike in ICP during the fasciculation phase, there is no convincing evidence that this has any impact on long-term clinical effects for neurologic outcome. The advantage of rocuronium is that it's non-depolarizing, so you don't have that hypothetical ICP spiking effect, and there are just fewer contraindications to worry about in the heat of the moment. Plus, it tends to keep the patient still during critical transport periods, either during imaging or transport to another center. Basically, take your pick based on what you're comfortable with and what you have readily at hand. For post-intubation sedation, I tend to use propofol and fentanyl infusions in combination if the patient is normotensive or hypertensive, whereas I tend to use ketamine infusion instead if the patient is hypotensive. We need to remember that our work is not done just after the tube passes the cords. It's also important for us to ensure that neuroprotective ventilation settings are appropriately applied. For me, this typically looks like ventilator settings of a respiratory rate of 16, tidal volume of 8 cc's per kilo, FiO2 of 100%, PEEP of 5, and I'm targeting a PaCO2 of 35 to 40 and O2 sats of 94% or above. If I have a few additional minutes to prepare in advance, I might consider optimizing by including a few finesse items, but only if I and my team have the bandwidth to do so. These are nice to haves, not need to haves. So for me, this would include fentanyl, 3 micrograms per kilogram IV at about 3 minutes prior to intubation. So again, we're going to ballpark at about 200 micrograms for an average size adult if the patient is normotensive or hypertensive. I do not give this if the patient is hypotensive. I might also ask for a lidocaine spray for the cords to reduce the ICP spike that can occur with any laryngeal stimulation. So the next time you're faced with the challenge of a neuroprotective airway capture, remember, 1. Consider airway management prior to imaging or transport with a lower threshold for airway capture in the setting of active vomiting, difficult to control agitation, rapidly dropping GCS, or dysregulated breathing with apneic spells. 2. Include a 10-second brief screening neuro exam if possible, looking at GCS, eyes, and lateralizing motor response. And 3. Keep your approach simple, using the techniques you are most familiar with. Just remember to avoid hypotension and hypoxia, and you and the patient will be just fine.